I would ask that pharmacy students exit on this side of the auditorium, and please be sure to give your last name as you exit through the door, because we'll have some folks assisting this morning that normally do not know you by sight. So if you could please make sure, we'll do our best to get you through as quickly as possible if you work with us. So with that, I will turn it over to those who have planned convocation today.
Good morning. Good morning. Good morning. That's much better. This is a historic occasion, whether you guys recognize it, realize it, or not. This is our first interprofessional healthcare convocation here at the University of Charleston School of Pharmacy. So we have students as well as faculty and staff from the various healthcare professions at the University of Charleston. And we wanted to bring everyone together, not just in the classroom, but also in some of our co-curricular activities, such as Convocation, which is a natural activity for the pharmacy students. This activity, this convocation came about basically, about 6 months ago actually. October the 21st, 2015. Many of you all may recall that we had the President of the United States come to Charleston, West Virginia to talk on a very important topic. And that topic was about prescription drug abuse with the heroin epidemic, and that the Appalachian area and West Virginia in particular is ground zero for this issue. As a result of the President coming, it was a community meeting, and there were some persons from the University of Charleston who were fortunate enough to be able to get an invitation to that event. Those individuals were Jennifer Pack, who is our director of our physician assistant program, myself. Oh, yes, let's give her a round of applause. From the School of Pharmacy, Randall Steele, who is a fourth-year student, along with Jeremy Arthur, who is a P3, a third-year student, and myself. And Jeremy's right there in the audience. Let's give him a round of applause. And that event was very impactful for the four of us. It was an opportunity not just, of course, to hear from the President, but more importantly, to hear from persons who were impacted by this unfortunate situation of substance abuse. What it also helped the four of us to realize as we were talking after the event, standing outside, was that this was such a great event that we wanted to make sure that it didn't just stop with us on the corner of the street where the East End Resource Center was located. And we decided that we wanted to come together and see how we could do something similarly to that event for the university community, starting primarily with healthcare providers and those in training to become healthcare providers. And so after several meetings, we're here. And we're here not just with the pharmacy school and not just with our PA program, but we're also here with our nursing program and also with our athletic training program. And so this is, again, historic for, one, this event, but what we think is really going to be great is what comes out of this event. And so there was a planning committee that has put together what you are experiencing today for Convocation, what several of you will be experiencing in our leadership luncheon this afternoon. And hopefully from this event and the leadership luncheon, there will be a desire for the students, along with faculty and staff, to come together as an institution of healthcare providers and healthcare providers in training to do some significant activities around this event. And so I would ask that the persons who were part of the planning committee for today's convocation and leadership luncheon to stand and be recognized. Missy Lane, Jennifer Pack, Rich Patterson, Jeremy Arthur, is Sarah here? Sarah, and JP from Marriott. I always remember your name. JW Marriott. JW from the PA program. These are the individuals who spend spent some time really working to try to pull this event together. So let's give them a round of applause. So without further hesitation, I'm going to turn the program over to Ms. Elaine, who is in our nursing department, for her to introduce our guest speaker and get our program started. Thank you for your attention and best wishes for an enlightening convocation.
Good morning. My name is Melissa Lane. I'm a professor in our nursing program, and it is an honor and a privilege to welcome today Mr. Mark Eichbusch as a guest speaker for today's convocation at the University of Charleston. Mr. Eichbusch is the Director of Nursing Quality at Charleston Area Medical Center. He is a member of the board of the West Virginia Nurse Executives, and Mr. Eichbusch has most recently been a key speaker at the WVONE Fall Conference on Empowering Leaders and Igniting Change, where he spoke on the crisis of substance abuse. It could happen to you. I have personally known Mr. Eichbusch for several years now, as he hired me in my first leadership role as a nurse manager. It goes without saying, he had a positive influence on my career, as he has many others. Please help me in giving a warm welcome to Mr. Mark Eichbusch.
Yeah. Thank you, Missy. Well, boy, I get all kinds of surprises when I come here today. Missy called me about this yesterday, and so please don't hold that against me with this presentation today. I also didn't realize this was the first convocation you've ever had. So anyway, I'm here to talk about the crisis of substance abuse in healthcare. It could happen to you. I am a nurse, and I work with nurses who have substance abuse. And so a lot of my comments are going to be made in relationship to nursing, but any of my comments can cross over into any of the healthcare professions. But a lot of the comments there will be a nursing focus. All right. It is estimated that 10 to 15% of all nurses in the U.S. are addicted to some type of illegal or controlled substance. Now, nationally, the general population, it's thought, has about a 10% addiction rate. I personally think that that's a little bit low, but in healthcare in general, there is a higher rate of substance abuse, and a lot of that is due to the fact that we have a lot more access. So, why are nurses, or healthcare professionals, but nurses specifically, who are highly esteemed and considered by the Gallup poll for the last 14 years to be the most trusted profession to be so at risk for addiction? Well, there are a lot of different causes, or a lot of different thoughts. Number one, this equates to any profession in healthcare, but job stress. Long hours, stress related to caring for sick and dying patients, the work area. Nurses who work in the ER, the ICU, the OR, or in anesthesia have the highest prevalence of substance abuse because these are considered to be very high stress areas. And when you look at the data on West Virginia, we fit right into that. Easy access to medications. Those areas that we're talking about right there have very easy access, and they have they're actually a more uncontrolled environment than what a lot of other areas are, like on the floor. And pharmacy goes without saying that they have very easy access to narcotics. The workaholic personality leads to addictions, and there are a lot of nurses specifically who work many, many hours, and that can also lead to addiction. In general, nurses take care of others first and themselves last. That also crosses the span of healthcare. And what this does is it leads to the addiction to hide personal needs in order to tend to the needs of patients and families. And then nurses, and I think healthcare in general, lack the education to see addiction in themselves. So, what can a nurse or another healthcare provider do if they suspect a coworker is addicted to drugs or alcohol? The worst thing you can do is nothing. But approaching a nurse or someone directly will likely will likely meet with resistance and denial. You may instead want to talk to them about changes that you've seen in them without accusing them of, oh my God, you look like you're diverting or you look like you're high. That's not going to meet with a lot of people being very wanting to come clean with you right there. What my suggestion would be is that you report changes that you see in people to management. But don't accuse people of drug abuse unless there are obvious changes. Just because Missy comes to work one day and she looks sleepy is not a reason for you to say that you think she's high or that she's impaired in some way, shape, or form. That's not the right thing to do. If you see that, she doesn't come to work looking great anymore, and she looks sleepy, and she can't walk in her heels anymore, then you might want to say something to somebody. So just be very careful. Just be careful to not falsely accuse people of this. And there is a very fine line. Addiction is very insidious, and it's very difficult to pick up on in most cases, and so you need to be very careful with this. But I'm almost sure this would be true for PAs and for pharmacists. I know it is for nurses, but West Virginia is a mandatory reporting state. And what that means is if we find somebody at CAMC, or any hospital, and we know that they have been diverting narcotics in some way, or that they have some kind of substance abuse problem, it is mandatory that the agency or the organization report that person to the Board of Nursing. But in West Virginia, we have come a long way in the last few years, and we now have West Virginia Restore. So you can actually also ask the nurse if they want to self-report themselves to West Virginia Restore, and I'm going to go into that a little bit more. But they do need to be reported in some way, shape, or form, whether it's by the organization or whether it is by the nurse themselves. And what I want to do is do a little comparison. In 2013, the West Virginia Board of Nurse Examiners contracted with a group, and we now have a program that's called West Virginia Restore. The previous system, when a nurse was under contract, they had a 3-year contract, they had random drug testing, they had a requirement to go to 12-step meetings, they had to have quarterly reporting by their employer, they had to have monthly addictions counseling. but there was no requirement for inpatient or outpatient treatment. They did not have narcotic privileges for that entire 3 years. There were no RN case managers. There were no structured support groups. And what that did was that created a separation with these nurses, feeling like they were really very different from what they were before. And the whole focus of it was on discipline. We wanted to discipline these nurses because they had the disease of addiction. West Virginia Restore is different. West Virginia Restore, the nurse has a 5-year contract, and you think, oh my God, 5 years. That's awful. Well, you'll see it is actually a better situation for these people. They get random drug testing. They get drug tested 25 to 35 times a year. That is considered best practice. And so they are getting drug tested about twice a month, sometimes more frequently than that. We still have the quarterly employer reporting if they have gone back to work at the hospital. They have monthly addictions counseling, and they may have inpatient or outpatient treatment. And what that is dependent on is they are assessed by a certified addictions counselor, and that certified addictions counselor will make a decision and give that decision to West Virginia Restore and say, I think this person can do fine with monthly counseling with whomever, or they need to go into some kind of an outpatient treatment, or they need to get into a 28-day program. This, I think, is one of the most important aspects of this. After the nurse has been in West Virginia Restore for a year, they can reapply for their narcotic privileges. That gives the nurse another 4 years before they are out from under contract, but they're still being drug tested every a couple of times a month. And at the same time, they get their hands, as I put it, back in the cookie jar again. So it's actually kind of a safety measure for them. They do have RN case managers with Restore, and another incredibly important part of this is with Restore, they are required to go to a weekly facilitated support group, which is only other RNs who are in Restore, and they are, and that group is led by someone who is trained to be a facilitated support group leader. I happen to be one of those. I have done this since May of 2013, and I actually do 2 groups at this point in time. I'm going to talk about that a little bit more. But this focuses on discipline. There's still the discipline aspect of it, but it also is focuses on support and recovery. So a little overview of what's going on with Restore and people who are involved with Restore in this state. I didn't have enough time to update this slide and get the information from West Virginia Restore, but when I gave this presentation the last time, in the second quarter of 2015, there were about 82 nurses that were in the program who actually were under contract. There were probably, there were 12 in that particular quarter. First quarter, there were 24 that were pending, who were in the process of going through those assessments and that type of thing. I would say today there are probably 120 nurses who are under contract with West Virginia Restore. And you can also see that 47 were reported from the board, and 34 were voluntarily reported, where they called West Virginia Restore and said, I have a problem. What can you help me with? All right. Substance usage. You can see that now. I want you to also keep in mind that this is West Virginia Restore asking the nurse, you know, how many substances did you use? Did you use one, or were you a polysubstance abuser? So this is just what the nurses told them. 33 said that they were single substance users. They were pure plays. They only took one. But 47 said that they were addicted to 2 to 4 substances. And 2 actually admitted that they were addicted to 5 to 7 substances. The reality of it is, as far as I'm concerned, all 82 are polysubstance abusers. The only reason they're not polysubstance abusers is because they didn't try them. If you have the disease of addiction, whether it's alcohol, narcotics, pot, whatever, if you try something else, I have a feeling you're going to like it. So the reality of it is, you know, I will have my West Virginia Restore nurses talk a lot, and, you know, it's very open, and they are very open with me and tell me things that I never knew. But, you know, I've had 1 or 2 people who've actually graduated, and before somebody was graduating one time, I overheard somebody else say, well, you know, you really just took Vortex. So when you get done, are you going to drink? Well, that wasn't the right thing to let me hear. And so, consequently, that whole group turned into, what are we going to do about our addiction for the long term? Because this disease does not go away. Once an addict, always an addict. The only difference is you're not using when you're in recovery. So consequently, my belief is that you could be a heroin addict and you could be clean from heroin for 10 years and you start drinking wine. The same centers in your brain are activated and you're just going to become an alcoholic. Maybe not immediately, but over time, those pleasure centers, you're going to be stroking them enough that you're going to start to think, you know, this wine stuff is pretty good. This alcohol is pretty good. So my whole point is if you think you're a single substance abuser, you just haven't tried the other things enough. Substances of choice. This is not really surprising. 67 said that they liked opiates. Dilaudid, or hydromorphone, is the #1 drug diverted by friends in this area and nationally, not just in West Virginia. One of the problems with Dilaudid is Dilaudid has been a drug that has been around since Florence Nightingale and I graduated from nursing school. And Dilaudid comes at CAMC in 2 milligram amps. It came in 2 milligram amps because when I got out of nursing school, you gave everything IM. You didn't give anything IV. So they would give 2 milligrams a lot. The reality of it is, today, we give everything IV. So you're giving 1/4 of a milligram, you're giving 1/2 of a milligram. Now you have 1.5 milligrams to waste. And I have somebody that's in my group in one of my groups. He's been clean for about 3 years now, or almost 3 years now. And his story is he had a problem with kidney stones. He went to the hospital for his kidney stones, and what did they give him? But they gave him Dilaudid. And he thought, I kind of like this. He was an ER nurse. Several months went by. One night, it was a particularly busy time in the ER, and he got home, and he realized in his pocket that he had 1.5 milligrams of Dilaudid. And it was a bad night. And so he thought, wonder what this feels like when you aren't in pain. And what he found out was that within 3 weeks, he could not divert enough Dilaudid that way. It immediately took hold of him. And, he was off to the races. And I have heard that type of story more than once. So anyway, opiates, very big. Fentanyl is really big with people who are in the anesthesia department. Alcohol, 18 people. And then you have to have a few benzos in there. Bump and Xanax is given out like candy, it seems like today. Guess I should stop pointing at the slides. All right, my personal experiences with West Virginia Restore and being a West Virginia Restore facilitator. Like I said, I've been doing that since May of 2013. I have 2 groups. There are 10 nurses. In my Tuesday night group, about half have been with me since the very beginning, about a split of 50-50 males and females. There is a higher rate of substance abuse among male nurses. Statistically, we don't know why, but it's just a fact. And the Wednesday night group has 6 nurses. They're all fairly new, and that's all female. Some of these people drive over an hour to come to my group, but there are a couple of groups that are done by conference call. I have a problem with that because it's very important for me to see these people and to be able to interact with them more directly. This is the scariest time in these nurses' careers. There is a great deal of remorse, blame. I have heard over and over, I was a good nurse, but I'm an awful person. And I try to get across to them, you are not a bad person trying to get good. You're a sick person trying to get better. Most of the time, before they get their narcotic privileges back, it's very difficult. They have to surrender their license to the board, so they can't practice until that whole process is taken care of and the assessments are done. But after that, they can actually get a job. But it's really difficult for a nurse to get a job if they can't give narcotics. And so, a lot of these people are the main breadwinners of the family, and just about there's 2 places locally that they can get a job before they get their license back, and that's working in a dialysis center or for a company called CCIL where they do case management. There is great camaraderie among this group. They care about each other. The biggest thing is they understand each other and they help each other. It's absolutely amazing to see how they grow in their recovery. And I had to add one thing. The Tuesday night group has actually had 3 babies. 2 of the guys' wives have had babies, and one of the ladies had babies. So families do come back together after this. I had to laugh when, Missy said, we want you to talk about what does somebody who has the disease of addiction look like. Well, what I can tell you they don't look like is they don't have big discs in their earlobes. They don't have obscene tattoos all over their body. You know, they're just one of us. But some of the things you may witness is some behavior changes. Somebody may seem agitated, or they may seem really hyped up. They may be sleepy. They may not be able to keep a consistent train of thought when you're trying to give them report or whatever. You may see absenteeism in these people. And a lot of times, the addict may call in sick the day after they've had a weekend off because they have misjudged how much they've used, and they just can't make it to work on Monday. You may have an odor. About the only time you're going to have an odor probably is with alcohol. But you'll also see somebody who used to be on the floor all the time or in the department all the time, and all of a sudden they will just disappear for periods of time. They'll be gone for 10 or 15 minutes. They haven't told anybody where they've gone, but they're just gone, and all of a sudden they come back. They may want to give everybody narcotics. Hey, I'll help you. And you know what? Everybody likes them because they're doing their work. But what they're really doing, or they may actually go and make rounds around the unit and ask if anybody wants anything for pain. People who haven't necessarily gotten something for pain in the past. And all of a sudden, they're just going to help Missy out, you know. And so they go and give that narcotic for them. They're very helpful. But it's also very questionable wastage. And what I will tell every nurse in this room, you do not ever sign for somebody else's wastage unless you have seen them waste it. And the preference would be that you see them draw it up out of the vial and waste it right then. It's really difficult to do that because if you see them squirt something that's in a syringe down the drain, you don't know what that is. But don't ever waste anything. I wasted that, about an hour ago. When you put your coat in here, don't ever do that. They are well-liked people because they are so helpful. They tend, and I question putting this on here, they are great nurses. They have to be great nurses. They have to be great pharmacists. They have to be great PAs. Because if they're not, they'll be suspected. They can't be sloppy. These nurses will have great documentation, and they will do things right because they don't want any attention brought to themselves. Their documentation of pain assessments and all of those things will be impeccable. Now, what I will tell you is as the addiction progresses, that starts to taper off because they can't divert enough that way to be able to get enough narcotics. So, what the addict may look like is they may look like your grandparent, they may look like your parent, they may look like your sibling, or they may look like one of your friends. The reality of it is, do I look like an addict? Nobody wants to answer that question. Of course you do, old man. The reality of it is, I'm an alcoholic. And I have been in recovery for 11 and a half years. And the reason I'm here is I crossed over into alcoholism when I was about 22. That's a long time ago. But I crossed over into alcoholism when I was probably a senior in college because I liked to party. And I did. And I did a lot. I'm sure none of you do. And so I'm not saying that. But the reality of it is I crossed over into alcoholism. The thing is I didn't know I was an alcoholic. I didn't know I couldn't quit. Why would I try to quit drinking? I'm the life of the party. But that's where I was. And you know what? From the time I crossed over into alcoholism, I did not get sober until I was 47. So during that period of time, I drank a lot, and I did a lot of things that were not very good to me, my body, or my family. But the reality of it was I never really tried to quit. So I didn't know that I couldn't quit. So I didn't know that I was an alcoholic. I like to dabble in other things also that we just won't go into. But the reality of it is, I was promoted. I went through graduate school, and I was promoted 4 times. I have been a chief nursing officer for over 20 years. And in fact, Missy didn't know this about me, but I was a full-blown alcoholic when we worked together. But guess what? I didn't have a problem because I didn't drink at work. Now, Katie barred the door. When I got off work, it wasn't a pretty sight. But the reality of it is, I went to work every day. I was never gone, was I? The only reason I didn't get addicted to something, I might, when I have spoken before at AA meetings and things like that, I've said that I was addicted to heroin. I've never used heroin, but I think I'd like it if I ever did. The reality of it is I have the disease of addiction, and I always will. And the reality of it is, I don't ever have to feel like that again. So, I just tell you that because when I was sitting out there like you all, I thought it was all just a lot of fun. And you know what? I did have some fun times, but I had some not so fun times also. And so, the reason I tell you that is sometimes we do have, and that's why I entitled this, the disease, the crisis of addiction. It could happen to you, because it did happen to me. There is successful recovery from addictions, though. It occurs over a long period of time, often involves multiple attempts. A lot of people relapse over and over and over again. I know people who have gone to a treatment center for 6 or 7 times, and they finally get it. It consists of self-change and or treatment, and it involves changes in other areas of psychosocial functioning. So anyway, that's it.
Before I allow time for question and answer, I also would like to ask Pam Scott if she wouldn't mind to say a few words. Also, she is on the West Virginia Medical Professions Health Program Board. That board is for anyone licensed under the West Virginia Board of Medicine or the West Virginia Board of Osteopathic Medicine. So that board helps to identify and provide support for physicians, physician assistants who have an addiction. So I'm going to ask her to come and just speak briefly. She has a mind about that program to let you all know that program is available as well. And then we'll allow some time for question and answer for both parties.
Thank you, Jennifer, and it's certainly a pleasure to be here with you all today. The West Virginia Medical Professional Health Program, as Jennifer told you, is for individuals who are licensed under the licensing board. But we also incorporate students of those disciplines. So medical students, physician assistant students, and podiatry students can also participate in the program. What it is it's a confidential monitoring program that provides support and resources to individuals who are recovering. Now, it not only encompasses substance use disorders, which of course includes alcohol, but it also does major psychological disorders. So bipolar, schizophrenia, depression, anxiety, those type things are covered as well. One of the big things about the program that I would like to stress is when you go to apply for your medical license in any state, it's going to ask you, have you ever been treated for alcohol use disorder, substance use disorder? Now, when you flag those yes, obviously things happen. The board starts an investigation. They want documentation as to what happened. If you have a substance use disorder and you just get a hold of the West Virginia Medical Professions Health Program, become one of their participants, the law actually allows you to not have to disclose that to the board. And the reason why you really don't want some of these things disclosed to the board is they can result in consent orders. Those consent orders actually flag the National Practitioner Data Bank. So you have a data bank report then, and that follows you around for the rest of your life. One of the things that we do that's a little bit interesting is employers do have to report to the board if they find an individual with a substance use disorder or a major psychological disorder. Anytime that there's an impairment where they suspect that the healthcare provider cannot practice to their fullest. So basically, what the number one goal in all of this is patient safety. That's the number one goal. Now, after that is the care of the provider. So some hospitals, administrators will get these people and get them to voluntarily go into the WV and PHP, and then the appropriate evaluation and treatment and so forth. So I guess at this point probably you will open it to questions or.
We'd like to open it up for questions now. If you have questions for either of these people on the stage or for any of the other faculty.
Are there any questions we can entertain?
Ma'am, it's for you, so I'm sorry, I can't remember the name. But if the goal for us is to provide patient safety, whether you're in nursing, pharmacy, doctors, physicians, assistants, then why should they not have to disclose the information to the board that they are in a program?
Basically, it's because the fact that they are in the program, they're being monitored. Usually that first year, the individuals in our program have urine drug screens at least once a week. They've gone to treatment. They've got a addiction counselor in place. They go to AA. They may go to NA. They go to Caduceus meetings, which are similar to AA NA groups that only have healthcare providers in them. So they're under monitoring and they're under treatment. And that way, they're not returned to practice until it's proven that they're safe. So you may get an individual coming back from treatment that may not be able to practice for 3 to 6 months. But they're not put back into that situation until it's felt that they can safely perform. Then when they do go back to work, it's only in a part-time capacity. So what it allows is for individuals with problems to come forward early without the fear of being sanctioned by the licensing board.
Okay, thank you. And can I ask you one more question, sir? If the basis for, I guess, substance abuse is the ICU settings for nurses and the ORs and ERs where they have access to it, after they complete the program, are they still able to go back into those settings, or do they have to be, I guess, moved to a different setting?
Yes, they can go back into the ICU, the ER, or wherever. I don't recommend if they left a hospital that they go back to that same department, but I have 3 of the nurses in my group that are actually ICU nurses.
Are there any other questions?
So I have a question for Pam. So just going off of what you were talking about, so you wouldn't have your license taken away if you came forward yourself to get into that recovery group, is what you were saying?
Basically, if you are in the program and compliant in the program and came to the program voluntarily, which means you yourself, your employer, your family, somebody got you there other than the medical licensing board, then basically there's going to be no restriction on your license. But if a patient reports you to the board, then an investigation goes forward, and if something's found out, if another member of the staff reports you, once the board action's there, the board action's there. And anybody that's not compliant in the program are also reported to the board, and the board takes immediate action upon that.
And I do have one other question real quick. Is for students, what's the protocol? How do we find out about how to do anything as a student in terms of the recovery, or, because you said it was for students as well, I just don't know how to find out about that or where we could find information about using the program.
Basically, for students, I would first recommend going to the website, which is wvmphp.org.
Okay, thank you.
And certainly call me, call them, call Jennifer, she'll have the numbers. So, glad to help you.
Thank you.
All right, well, I'd like to thank everyone for coming. Again, the purpose of this was to expose us as students to more of an interprofessional environment, because a lot of the people in this room may be our fellow coworkers when we get out to hospitals and things like that. For those of you attending the luncheon, it will be upstairs in the ballroom, and if you have any other questions, I'm sure our guest speakers can remain up front for a few minutes afterwards. Thank you.